morning, everyone. Thanks for joining us for this year's first in-person Grand Rounds. We have a very special speaker today, special not only because of the amazing work he's done throughout his neurocritical care career, but also because he's returning to NYU as an alumni of our neurology residency program. Dr. Geocadin is currently professor in neurology, neurosurgery, anesthesiology, and critical care medicine at Johns Hopkins University School of Medicine, and is also currently the co-director of the Johns Hopkins Encephalitis Center. He got his Bachelor of Science at the University of the Philippines, an MD from the University of the East RMMC College of Medicine in the Philippines. He completed his medicine internship and neurology residency here at NYU and his fellowship in neurocritical care at the Johns Hopkins School of Medicine, and has been there ever since. He has been recognized and awarded by the neurology and neurocritical care community extensively throughout his career and has been a leader in these fields throughout this period. Some highlights include serving as the director of the Neuroscience Critical Care Division at Johns Hopkins, serving as the chair of the Education Innovations Committee and on the board of directors of the ANA, and also previously serving as the president of the Neurocritical Care Society. He's also held multiple clinical and research leadership positions related specifically to anoxic brain injury in the setting of cardiac arrest, and this is a field in which Dr. Geocadin has been published extensively, and where he's been integrally involved in developing the post-cardiac arrest neurologic prognostication and management guidelines that we use on a daily basis. Currently, he's an active PI for the ICECAP study, which is a clinical trial focused on investigating therapeutic hypothermia in cardiac arrest patients, and has multiple additional grants for ongoing studies focusing on cardiac arrest and anoxic brain injury. Dr. Geocadin, thank you for joining us back at NYU today. We look forward to your talk.
Thank you so much. This is homecoming for me. And I was just telling Andy and Harold last night, and Dr. Prasad and Dr. Houston about the adventures and about how I ended up in neurocritical care, because my nights at Bellevue were some of the most awful nights. In the emergency department, that at one time the neurosurgical ICU banned me because I would bring 2 or 3 or 4 ICHs a night. And then, so I was like the biggest black cloud trap during that time. And then Kate Henry came to me and I was literally crying. I don't know if you know Kate Henry. Kate said, Romer, you have 2 choices. Either you run as fast as you can or you embrace it. And then he said, by the way, Dan Hanley at Johns Hopkins is a relative of mine. And you know what happened from that point on. And it was even weird because at that point, there's only 4 programs then that train people. And Hopkins was a weird can of worms because you cannot just apply. They want you to do a whole month of neurocritical care, which in fact is your audition. So you're there, and if they like you, they would invite you for an interview. So you know that after your month rotation, if there's no invitation, that's it. You were slave labor. But that's it. So that's how we did. So during this time when I was there, I was with Adnan Qureshi, Jose Suarez, these people who wrote many of the key things right now. But anyways, let's talk about this, because this is so when, and I was just talking to Oren Davinsky, and I don't know for people here when you look at my CV right now and pop my name on PubMed, you would say, what happened to this guy, right? Because when I left NYU, can you guess how many papers I have? 1, right? And it is a paper with Oren Davinsky, where I am right smack in the middle, that they were gathering all of this data on pseudo-seizures. But that was in publication during the time. We have 1 publication really on my CV when I applied. And it is really a case report on, it was actually with Peter Nelson. They were injecting pain medication in the spine, and something happened. It spilled, right? There was 1 patient, there were 7 authors, and I was number 5. So I was really the meat in the sandwich of anonymity in that paper. And so I was telling everybody, like, maybe Henley was really desperate. Anyway, so that's it. That was like 1997. So fast forward when I got to Hopkins, and I don't know if you guys are familiar with Dan. Dan is a quintessential mentor. He will actually find how good you are and encourage you. So he started assigning topics to several people, like ICH to Adnan Qureshi. This is why ITAC trial came to be. Jose Suarez was subarachnoid hemorrhage with everything that they do. And he said, Romer, brain injury after cardiac arrest. And of course, Romer, the small frontal lobe guy, told them, Dan, why am I doing cardiac arrest? There's nothing there. And he started laughing, and I'm telling this for the junior people. He said, Romer, there's nothing there. I told him, Dan, there's nothing there. I said, perfect. If there's nothing there, nobody can tell you you're wrong. Or if you publish something, they have to cite your paper to prove that you are wrong. At the end, both of it, you win. So that's how it started. But anyways, so this is like 20 years, I don't know, 22 years later, and probably about 200 papers after that chutzpah response to Dan, but Dan, there's nothing there, right? And so right now, I have no commercial funding, as mentioned by Isaac. I'm PI of a UG3, which is the ICECAP trial, 63 centers all over the United States. And I have an RO1 in the lab, understanding for the last 15 years. Actually, the model I started when I was a fellow, and then it evolved into an RO1, looking at the mechanisms of injury. Right now, our grant is to understand how cerebral autoregulation recovers after CPR, which is sad, right? Because we really don't know how the brain comes back. So fast forward, plus precise cap, and I'll talk a little bit about this. I talk fast because that's just how my brain is, but I'm motivated that I have 60 slides, okay? But you could stop me and say, Romer, hold, slow. So, we'll talk a bit about pathophysiology, and then we'll talk about, the temperature, the hemodynamics, and all this and all that. But the important thing about this is, and this is, of course, a Hopkins-centric bias. So just let's step back 1960s. What were they doing then? So this was William Cohenhoven here overseeing one of his residents doing external chest compression. So this was actually interesting because this thing evolved, and I'll be very quick with this. And I don't know if you know the Blue Baby, and there was a technician played by Cuba Gooding Jr. And so they actually did this. So they instrument a dog, and what happened with the dog is they were instrumenting them before they go to his lab, to Vivian Thomas's lab, the dog arrested. The dog arrested in the old building, and there were no elevators. So, and they spent a day. So they did, can you just, because every time they pressed the chest of the dog, the A line would go up. So they started to do external chest compression, because during the time they had the money from Con Edison to develop external defibrillator, right? Because Con Edison discovered that they have linesmen that would hold one end of the line and the other end of the line, and they zap, and then they lose consciousness. And they gave $50,000 to Cohenhoven and Johns Hopkins Engineering to figure out. And this actually is the start of the AEDs. But fast forward, so they see this undulation in the A line, and they said, maybe we do chest compression, external chest compression. And so they did this on the dog, right? And then they ran this dog to the lab of Vivian Thomas, and then they defibrillated the dog. And the dog, there's actually a footage of the dog at Hopkins, right, on this. So there's like a museum there. But anyways, fast forward, they did that, and they did this on patients, and this became a JAMA article in 1960 on closed chest cardiac massage, right? 1.6 miles the other side is Peter Safar as an anesthesiologist at Dan Francis Scott Key, right? Laura is nodding her head because this is probably all familiar stories to her there as a student. So Peter Safar at Bayview Hospital is an amazing guy, because you know what he did? He's the one, if you use A, B, C, D, he's the one who started all of that. And Peter wanted to understand airway, and you know how he got, this was like 1960s, no IRB yet, right? He paid medical students $150 and gave them curare and did mouth-to-mouth resuscitation himself. Because we celebrated the 50th anniversary of this, and we looked for these students. We found two of them. One became a psychiatrist, so you probably understand some oxygenation problem. And the other became a surgeon, also an oxygenation problem. So Peter and his family was there. And so actually part of me, my lab model came from Peter. And I'm close to the Pittsburgh group, right? And so this is Peter here. So I have so many Peter Safar stories, including the first ambulance that they did in the United States, because how will you fit a guy lying down, right? So they took a hearse. And people were freaking out because they're not dead yet and they're getting stuck on a hearse. But that's the development of the first EMS. But fast forward. So on one side, you have external chest compression. On the other side, you have ABC. Put them together in 1960s in a cafeteria in Wall Street. It became CPR. Okay. Now, the issue with that is very successful. Thank you so much, gentlemen. The problem is so this is from Peter Safar, BRCT, Brain Resuscitation Clinical Trials. You see very quickly here that the outcomes are bad, right? Overall survival, when you do a patient cardiac arrest, you resuscitate them, they wake up, they don't go home, they actually go to the ICU and die. Only about 20% of them recover, and when you look here, what is the primary cause of death? This is our issue as neurologists. And I see Sam Parnia here as a medical intensivist, cum neuro person, is 20 to 1/3, 20 to 33, 35% of the cause of death of these people after Caleb is cardiac arrest. This is probably too familiar to you. You've heard me talking about this thing since you were in training. But anyways, I keep talking. I haven't changed. It's called research focus. And the thing is, what happened to the survivors? Half of the survivors are comatose. So you see here, right? And so what did the field do? The field did all sorts of clinical trials. And I call this the graveyard of clinical trials on neuroprotection because nothing became successful. One after the other. This is just the list of RCTs, right? They're all familiar. Like, what the heck is thiopentol? Thiopentol is a barbiturate. The problem is you give it, you think that you're protecting the brain, except that you drop the blood pressure down the floor. And the same glucocorticoids, you give them more infection, imodipine, it works in subarachnoid hemorrhage, not in cardiac arrest, blah, 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 blah. The bottom line is none of this worked, right? And then this thing happened, right? So right about in early 2000, therapeutic hypothermia started, which is actually an interesting event because I don't know, I mentioned the thing about Peter Safar. When I was actually a resident, Dan Hanley said, okay, you have to do this, but then do we look at these patients? I said, no, let's go to the lab. So we went to the lab. I was in the lab trying to do cardiac arrest and resuscitate. For the life of me, I was a PGY-6. I could not resuscitate a rat. After my 30th rat dying on the table, I stood up into Dan's office and said, Dan, I quit. I just want to be a clinician. And then Dan looked at me, no, give me the best paper model that you could find. So I researched and I found Peter Safar's paper. So I went to Pittsburgh. And during the time Peter Safar was still alive, and he taught me, actually he gave me a lot of things, but including, and at that time, maybe Sam knows this name, Bob Newmar, who's now chair of emergency medicine at Michigan, was there as a fellow. Cliff Calloway was there as a fellow. The guy who led the Haka trial in Austria was there as a fellow, and I'm there as a visiting, whatever. So we met, and then fast forward 10, 15 years, we all met in the ACLS guidelines committee, right? But bottom line is, it's amazing how this happened. So let me review this because, as I said, I have a lot of slides. The intro is a little more like, it's not really cerebral, but it's more touchy-feely for me. So why is this important now? Why are we focusing? Because the outcomes has not really changed 20 years later, right? When you look at this is the Telstar study. If you're not familiar with the Telstar study, it's the New England Journal study that look at any kind of borderline EEG abnormality and what was the outcome. Look at the mortality rate. It's about 80%, 20% survival. How different is that from the Peter Safar trial in the 80s? No different, right? But the thing and that I'm fighting for is this: withdrawal of life support, 70 to 80%, right? Why do we even bother if we pull the tube after 2 or 3 days? We'll talk a little bit about that, right? So just because I know we have residents and trainees, I have to review this. What is the impact of global ischemia for the brain? This is not like a stroke, right? It's the entire brain. There are selective areas. The most selective area, obviously, is the CA1 of the hippocampus and the neocortex. And then, of course, there are relative vulnerabilities in the brain, like the thalamus, the basal ganglia, and the caudate, and then the relatively ischemic tolerant part, right? 820. And here, this is from Will Longstreth here, and I don't know if you could see it. It actually gives you on the x-axis the duration of brain ischemia, on the y-axis the degree, and here's some categorization. And the thicker line here is the cerebral cortex, and the thinner line is the brainstem. So you see there's on this representation, for example, here, that in a vegetative state patient, right, and this is the degree of brain injury, your brainstem is still intact, which gives you the idea that the brain, so you have reflexes, you have pupils, corneals, cough, gag, but you are unresponsive because your cortex is gone. Your thalamus and neocortex, CA1 of the hippocampus, is wiped out, right? It's gone, right? And so that's the setup, and that is our problem. You go to the MICU, you go to the CCU, you get consulted. The first question is, can you prognosticate? And when do I pull the plug? And that is really the role of the neurologist forever when I was growing up. And then I kept fighting. No, we should fight. And I was the only one, I think, very early on. And that the AAN gave up and they made me chair of the course because I'm too bullheaded, right? And then I brought Peter Safar to come in and many other people that ended up becoming a guideline, because the problem during the time is this disease was just a prognostication indication for neurologists, right? I said, it's ischemia, it's like a stroke. And then Walter Korschatz, this sort of changed because Walter Korschatz, who then was the director of the neurocritical care at Harvard, started saying, global ischemia cardiac arrest is the biggest stroke the brain could ever have. And it changed people's attention, right? Because before that, it's gone, we just prognosticate, and because of what the people at Cornell did, right? So Plum and Posner, not Plum and Posner, but then there's the 3-day rule that they just take there's no hope after 2 or 3 days when you have this science, right? There's a nice computational percentage that based on blah, blah, which is like wrong. Now we know that there's a lot of error in that paper, but moving forward. Now, okay, so at the AHA, Lance Becker, who some of you are familiar with, led this group talking about what are the outcomes that we could use. So one of the key outcomes really in cardiac arrest is that, does the patient wake up? Is the patient following commands, right? Because that's the major bifurcation. If they follow commands, then something could be done. If they're comatose persistently, then the treatment is different. Okay, so what's this? Can you imagine that 50s and 60s we did CPR, but the problem is post-cardiac arrest brain syndrome was never formally codified until 2008, right? And this is a bunch of experts that are mostly EM guys, cardiologists, and then there's a familiar dude here. I was the neurologist together with Will Longstreth. So we tried to define what is post-cardiac arrest brain syndrome. And it's actually made up of 4 entities. Number 1, post-cardiac arrest brain injury, because many of the patients have intact heart, lung, and all of these things, but they're comatose. And then the second one is post-cardiac arrest cardiac dysfunction. And then the third one is the systemic ischemic reperfusion, like everything that happens. And then the last one is whatever caused the cardiac arrest. Yeah, so here. So mostly cardiologists, intensivists, nobody really was focusing on this very early on until now, right? And then we realized that the biggest determinant of functional outcome is neurological injury, meaning that if they recover from coma or not. And if they recover from coma, could they do things independently? So if we protect the brain, they have a chance, right? And so that's what happened. And so these are just some of the cartoons of the general concept of brain injury. because so we have to start, and I'll start talking about the recent clinical trials and my clinical trials. I'll be a little quick now. So here, so this is cardiac arrest. The key thing really is the injury dose, no flow time. Like for example, when somebody keels over, boom, right? And nobody is doing chest compression, that is the time of full ischemia time. And then somebody like a good Samaritan jumps in and do chest compression. However awful your chest compression, you're still, that's still better than no perfusion. But the best chest compression ever can only do up to 40 to 60% of a normal spontaneous ejection fraction. And can you guess who these people are? Are they doctors, interns? EMS, yes, yes. So actually I say this all the time. If I have cardiac arrest and I keel over, look for an EMS, right? The interesting thing is, oh yeah, interns. Yeah, they did it like 2 days before they started internship and never again, right? Or until they get to their MICU rotation, and during their MICU rotation, they did it twice. EMS do it all the time, right? So there's a nice study of this by Joe Ornato and the Seattle group that EMTs are. But having said that, so, and then what do you do because you have brain injury? And then you start thinking of what is the intervention that we think works, right? So it's the depth of temperature, and we'll talk a little bit about that because now there's this whole issue that confuses everybody. Should we do 33, 36, or 37.8? And where does that actually stand? And the other thing here is time to target. Time to target is important because time is brain, right? The longer you wait, the more ischemia you have, right? And then the last part is the duration of temperature. And that's the problem because people think, let's just start 36 and walk away. No, it's a dose, right? It's like when you take an antibiotics, it's not only the kind of antibiotics, the type of antibiotics, the strength of antibiotics, and the duration of antibiotics. Think of therapeutic hypothermia as an antibiotic, and you'll get it. So those are the simple variables. And then the most important time is what? Time to heal, right? The biggest problem in cardiac arrest is that, oh, they're comatose. We gave this drug. They're not waking up. Dude, it's 2 days, right? And then you walk away and you say, let's pull the plug. They have no hope. Did the drug work or not work? You didn't know. Patient died because the drug didn't work. Patient died because of your bias that you think they're not waking up. And we'll talk a little bit about that because then that's the issue that is actually one of the bigger issues why clinical trials in acute medicine die one after the other. Because in general, when you have, for example, an effect size of something, let's say 7% effect size when you give this drug to that entity, you do it, you have an effect size of 7%, but you withdraw care in 30 to 40 and 50% of that population. That effect size gets washed out. The trial will be negative. It's not scientific. You are not, the drug didn't treat you. You messed up your study. But anyways, so time to heal is very important. And with this, so we have the ICECAP study. And for the time to heal, it's neuroprognostication. We actually have the precise CAP study. I'll talk a little bit about that. So the general concept is for the inclusion criteria for targeted temperature therapy, and targeted temperature therapy as a general concept is like any temperature manipulation after cardiac arrest, right? So patient becomes unresponsive, and I'm really hoping that NYU becomes a site for ICECAP, and I will come here and in service the place myself. But anyways, so unresponsive, and it's not GCS of 8. If the patient is rowdy, not following commands, it means the patient has global ischemia, right? They don't have to, be posturing, right? If they are not responsive or giving meaningful commands, they should. And the outcome that we're looking as favorable outcome by MRS or CPC, activity of daily living, and it's an pragmatic ICU trial, and prognostication is limited in all of these trials. So because several of us were screaming bloody murder that we shouldn't prognosticate early, when you look at the clinical trials, there's almost a general practice now that there's a moratorium of neuroprognostication up to 96 hours. Nobody prognosticates early. So that thing that developed in Cornell that says 3 days, that's discouraged strongly now. So this is the clinical trial summary. So all of the RCTs that includes therapeutic hypothermia. So the classic one is the HACA and the Bernard study. So when you look at this, on the y-axis is the name of the trial. On the x-axis here is the percentage of subjects with favorable neurological outcome. What is favorable neurological outcome here? It's the ability to do activities of daily living independently, right? Either by CPC and or MRS. So it's interesting because when you look at the Sentinel trials, right, the HACA study and the Bernard study. So when you look at the dark blue is the normal thermia control, and then the light blue is the hypothermia trial at 33 degrees. So when you look at this, actually has a therapeutic, so the absolute effect here is anywhere from 12 to 15% between control and intervention. So this spurred a lot of interest. And then, so there was a Kierkegaard study, which actually inspired us to do the IceCap study, looking at 48 hours versus 24 hours. And you see here, there's some indication this is not statistically significant because they had to stop the study because they ran out of money. So this is actually an underpowered study. So it's not significant, but there's some signal that 48 seemed to work, right? And then came the first TTM and the second TTM that actually claims that it's equal in terms of 33 versus 36, and the most recent TTM2 that actually looks at 33 versus 37.5, that's equal. And this is THAPCA. This is a negative study, but Hyperion, I like to highlight this. All of these studies are out of hospital cardiac arrest, meaning the patient arrest, let's say, near Central Park, somehow got to the hospital, that counts, outside of the ED. If the patient arrests inside the hospital and is admitted into the ICU, that's the Hyperion trial. For the Hyperion trial, it is actually positive. So the only thing that works for in-hospital cardiac arrest is 33. No other temperature has been studied. And what it does is for the quality of survivors' life, therapeutic hypothermia improved it significantly statistically. So remember that. I'll review that later. So again, this is an interesting approach here. So if you dichotomize out-of-hospital cardiac arrest and in-hospital cardiac arrest plus out-of-hospital arrest. So there's shockable rhythm and all rhythm. So the interesting part between shockable and non-shockable rhythm, shockable rhythm means that it's primarily cardiac, meaning that your problem is like monolithic. It's really just the heart. And this is what Bernard and HACA. So this is actually less injured, right? Because it's shockable, out-of-hospital cardiac arrest. And the reason why out-of-hospital cardiac arrest is studied because they're otherwise healthy, because when you're in the hospital and you arrest in the MICU, you probably have like 10 other reasons to be there. You have no kidney, you have one lung, and you're diabetic, and you arrest, right? So it's complicated in hospital. And then the TTM combined all of this. But the key thing to remember here is that this was done in Scandinavia. When you look at the bystander CPR, which is like 70 to 90%, and majority are shockable rhythm. And the reason why I'm pointing this out is that think about the population that you're dealing with. What is a New York City cardiac arrest patient looking like, and how many of those tourists actually in Times Square would jump and do chest compression? In Baltimore, the bystander CPR is single digit. You'll probably be in rigor mortis before somebody picks you up. But anyways, so this is the Hyperion study as we talked about, which is in hospital cardiac arrest, and only Hyperion is significant. So let's talk a little bit about the TTM2 study, because this is one of the big things right now. So the TTM2 study is actually a wonderful study, and they're helping us with IceCap, especially Hans Freiberg here. This is actually a study comparing 33 degrees to 37.5, which is really a fever control study. So all patients are put on a cooling device. If you start getting fever, they will turn the device on if you are on the fever control. If not, you just be 33 all along. So And then what they find here, so this is the result. So when you look at this, I just want to highlight a few things here. So this is so imbalanced because 80% in 79 to 80% in the groups are males. So when you really think about this, right, there is actually a male advantage in cardiac arrest by about 1.5 in terms of outcomes across the board, multiple studies. There's about like 7 to 8 studies populationally that looks at this. We don't really understand. Some of it is related to the percentage of withdrawal of life support. So there's some degree of paternalistic ploy that goes into this, that women are withdrawn sooner. I mean, there's some studies in China that looks into this, and I have a fellow looking into this project. But moving forward, I think this is really the crux here. Look at the bystander CPR, right? It's bystander CPR. You arrest in front of Times Square, somebody jumps. If you are in Scandinavia, 90%, 91 to 99% of it will be a witness arrest, and about 80% of them will do chest compression on you. I'll show you the United States data next. And so here's the cooling for that 37.5. So when you look at, so these are the temperature curves. And the target for the first one really here is 33 degrees. So 33 degrees here. It took them about 8 hours to go the target, right? If you're thinking about ischemia, can you just imagine? That's really late. But when you look at the normothermia, quote unquote 37.5, and remember 36 is considered hypothermia at this point. So for the first 5 hours, these patients who were supposed to be normothermic were in the hypothermia range. They're under 35. So all of these things sort of favor the normothermia group. And then one of the things that they will tell you is that arrhythmia was really bad. Arrhythmia resulting in hemodynamic compromise was more common in the hypothermia group, blah, blah, blah. And people got scared, right? Maybe we shouldn't do this. But then any person who actually reads papers with some degree of competence will say, if that was significant, why is the Kaplan-Meier survival curve and the plots here look identical? Meaning that this observation did not translate into a survival outcome or a quality of life outcome. So the arrhythmia was managed properly in the ICU, which it should be, right? So let's review quickly here between these two groups. Why do you think the TTM2 worked? Because they were dealing with a different population. Just think about it. They were dealing with 80% males compared to what is your sex difference in your population, bystander CPR of 70%. Shockable rhythm. What is your shockable rhythm? So really the question here is when you're seeing a patient, look at table 1. Does the patient in front of you fit the table 1 of this paper? And cardiac etiology 100%, right? Because this is the data in the United States. In the United States, only about 25% is cardiac, and the initial rhythm in the United States is only 18% shockable, and only 39% layperson CPR in the best of places where they report data. And this is like Seattle, Virginia, which are really active in the database. But when you look at New York City is sub 20, and Baltimore is sub 20. So I know I'm looking at Sam because this is probably something that we need to wrestle with here. And having said that, so what did Cliff Calloway do with this? So he started looking at the natural order of things. So he looked at over 1,000 patients, and they developed what we call the Pittsburgh Cerebral, the PCAC score, where they actually stratified the type of patients to whether awake, coma with mild cardiopulmonary failure, coma with severe cardiopulmonary failure, or deep coma. So mild, moderate, severe, very severe. And what they found was that for really, really sick patients, PCAC 3 and 4, when they were subjected to 33 degrees, they actually had a better outcome compared to the PCAC 2 subjected to 36 that had a better outcome. So there's some stratification. So that's one level of evidence. And because of that, I was actually asked to write the editorial for this in JAMA. And that's when I said that moving beyond one size fit all, because at the end of the day, we have to understand that this is a very heterogeneous group. But then we have to figure out how do we define. It's like almost, and that's the problem with neurology, right? Because when we're only doing GCS, oh my God, GCS is probably as crude or as dull as your hairbrush. We have to find something that's sharper to help us stratify, right? Right, Sam? We have to do studies and be sharper than a hairbrush. But anyways, and then there's a group in Seattle too, led by Nick Johnson. So they actually did 33 degrees, and when the 36 degree came out, they switched. So you see here the tip off of their study, and then they studied the outcomes, natural history, and what they found was those patients on 33 degrees had clearly better outcomes, neurologically or functionally. So the question really here, there is really something that is going on. And it should be based on the severity of that. And then the Japanese reported something too. But for us as the neurologists, so there's this paper actually that looked at 33 versus 36 degrees, looking at the severity of EEG. And what they found here is that depending on the degree of your encephalopathy, especially here on the mild encephalopathy, you actually phase shift the CPC scores when you treat them aggressively with cooling. And then and we all know this, there are patients that no matter what you do will die, and there are patients that no matter what you do will live, right? But the middle part here is, and we're talking about 10 to 20% of the survivor balance here. And if we're talking about like 300 to 600,000 per year, we're talking about like a good 200, about 100,000 per year here in the numbers. But anyways, and then the Europeans started saying, maybe we should just do all normothermia. And then Geocadin and group said, no, let's fight. Let's be a little more sophisticated based on the findings that are here. And so there's no such thing as one size fits all. Understand what is your population. And at least the bottom line that I always say here, right? When you have a community-based acquired pneumonia, it's beautiful to give ceftriaxone to everybody, but if the patient is hypotensive, then you have to change your antibiotic choice. It's the same thing for cardiac arrest, right? So let's do quickly here because I barely have time. So what do we do with the brain blood flow right now? So these are the things to understand. In the first zero, so there's the early hyperemia, and there's the hypoperfusion phase, and there's the normal blood flow phase. So my declaration here is I have an RO1 right now looking at this in animals and understanding what is actually happening. So the magic number that people go about, especially in the MICU or in the CCU, is we have to keep the person's MAP 65 or higher, or maybe even 60 or higher. Where the hell did that come from? Did we ever question? So that is actually one of the things that Dan Hanley taught me, because every time I say something, he would say, can you explain? And he would ask me, where did you get that? And then so you keep going down, you keep going down. And then when I started sitting at the guidelines panel, I started realizing that where do you actually get that? You have this room of about 10 or 20 people who don't know what to do anymore. They scratch their head and somebody would say, how about 60? And then we all agreed that it's 60. So it becomes the guideline, right? Which actually is really expert opinion. But the bottom line is, so this is really based out of sepsis. And then, so actually when you look at this post-cardiac arrest syndrome, where I'm partly guilty of because I'm here, one of the things that we try to define here is based on sepsis is the early hemodynamic optimization by Manny Rivers, published in 2001, that talks about MAP of 65 to 90 millimeters mercury, and here is early optimization. So this is why when you go about there right now, you have to shoot for about 65 because the patient will do poorly or you will. So we joke about this. When you have a phone or a computer, you have a lawyer, because the malpractice lawyers are very keen about this, and they always look at the blood pressure levels. And if so, they could always call Romer to help the defense, right? But anyways, so this is actually the key thing to understand. So this is how it started, right? So this is the Lassen curve, right? So when you talk about cerebral autoregulation, people say, oh, it's the Lassen curve. So here's this dude, Niels Lassen, at the NIH in April 1959, who actually created this plot, right? But when you actually read carefully here, number 1 and 2, drug-induced severe hypotension were drug 1 and 2. points 1 and 2, points 3 and 4 is drug-induced moderate hypertension, and points 5 and 6, normal pregnant women and normal young men, and then you go to 10 and 11, and then you start understanding what is the commonality of all of these people. It's just that they were able to get the cerebral blood flow and the range of blood pressure. And one of the things that Lassen has done is he has identified that dropping below 50 seemed to be the bottom that you will lose perfusion. Whether that's true or not, we live by that nowadays, right? And so this is actually what we live for right now, right? We start to look for this flat line, and we're all afraid of this bottom 50. And 65 is right about here because we give a little bit of a gap, right? And if you look at the Lassen curve here, there's no upward flow here, right? Nothing. But now when you look at the curves in textbooks, we see this beautiful whoop. That's made up by a few experts. And so it's all extrapolation and say, oh yeah, maybe if we keep doing this, this is what's going to happen, right? And when you're in the ICU, maybe the blood vessels start popping. Maybe that's what it is. So I don't know, but I'm a purist when it comes to data, right? So this is based out of the Lassen curve, and this part here is projected. And so there's an interesting thing here by John Drummond, who's a neuroanesthesiologist. The typical one-size-fits-all diaphragmatic representation of cerebral blood flow regulation that appeared widely in standard texts are likely to be misleading in several aspects. And what John did, he got all of these papers and looked at what point was that leg that caused the blood pressure drop. And you could see here across the board and across the entity that it's anywhere from 60, 79, 91, 88, 73, 79, and 68. So the problem here is this. We are all blind to this. We keep doing things until there's no more flow, and then the patient becomes unresponsive. Could we do TCDs? Do we have any measure that could tell us? How do we measure autoregulation at the bedside? I mean, there's a lot of things that maybe Arian or Sam could try to do that I could do, but no one has really validated this, right? So this is why the NIH had pity and gave us money to develop these little cameras that we use in animals right now. So here is, I have 13 minutes, the shock, right? We talked about a map of 65. What's a normal blood pressure? 120/80. Try to get your iPhone and compute what is the map of 120/80, and you will be shocked because it's about 93. It is not 65. We are all brain people here, right? What is 65? 80/58. Is that enough for the brain? And it's funny because when we look at sepsis, right? So when we look at the works, for example, of Mona Hopkins and Dale Needham at Hopkins. So would they do sepsis survivorship, right? And they find out they do MRI 6 months, 1 year down the road in survivors of sepsis from the sepsis guidelines. They find the brains of the sepsis survivors shrunken like demented. And then you say, oh, maybe that's the toxin. So I told them, no, that's because you're not perfusing the brain. The cortex is gone and the key points of the brain is gone. So sepsis patients behave like they have vascular dementia. At least that's my hypothesis because of this. So we have to fight back. But okay, so let's move forward here. So where does the evidence prove here? So there's one paper by Amilut. There's like about 6 papers here. One of the things, so Amilut is a cardiologist. So this is in JAC, Journal of American Cardiology, Congress for American Cardiology. So Amilut combined the trial. So this is a retrospective. He compared higher blood pressure to the standard pressure that we see, which is like MAP 65. And then based on that, he used pressors. So he found that by using pressors, you could actually separate, right? So there's no difference in baseline characteristics, no difference in cardiac angio findings. But the surprising thing is when they measured troponin C. Troponin C was lower in patients that have a higher blood pressure. They barely even measured brain here. So this is actually part of that data with amyloid. So when you look at the blood pressure here, this is the index that they had with the pressure, and this is the norepi dose, and this is the heart rate. So you could see that there's a difference. But when you look at the map of 80 and 85 compared to a map of 65, had a statistically lower and a smaller AUC for troponin C. Okay. If you're interested in the slides, just email me. I'm leaving this with Isaac here also. And the last one here is this. So where do we go now with this trial, the box trial, right? So they targeted 63 to 73. See, think about this. What is a 63 map? It's a blood pressure of 80 over 55. Could you actually survive? Some people, probably a third of the people in this room, when you have a map of 80 over 55, will have syncope. You will faint, right? Maybe not so much with 80 over 70, but that was the target here. No, I'm just saying this because then when you look at it from a very practical perspective, you will understand why the hell this trial was negative. So this is negative, and what they found was that there's no difference in terms of outcomes, and there's no difference in terms of injury, because there's really no blood flow to speak of, right? So people right now say, oh, yeah, there's no difference between 65 and 73. Let's all keep them at 65. And we, because I'll tell you, we have a panel actually working on this, say, yeah, maybe because there's no blood flow. If we accept the statement that there's no injury, therefore we stated, then we also have to accept that that intervention has no effect. Anyway, so that's the general theme, that it's probably too low. And the reason why I'm saying that is because we have this group. So this group, actually, I was part of the ACLS guidelines for 15 years. And so we were looking at the curves of survival outcomes over the times that we were there. And we actually decided that after 10 years, we vote ourselves out, because after a while, it becomes an echo chamber. It's the same people talking. It's the same people debating. It's the same people complaining about the same things. So we kick ourselves, the senior people. And then we picked a key topic. My topic was, how do we manage critical care patients after cardiac arrest? So we created a panel, because the other thing here too, if you write guidelines, right, because the literature evidence is so bad, you cannot actually end up coming with a recommendation that is solid. Everything that you say is hedging, which means that it is totally unhelpful, which means that it's not really going to change practice. So we have this guideline. So you could say, I'm here, that's Karen Hirsch, that's David Greer, that's Amorim, that's Ben Abella, that's Mary Kay Bader, that's Cliff Calloway, that's Theresa May, that's Emily Gilmore, that's Dave Cedar. So a lot of people who have done a lot are here. And we tried our best to make it well represented. Oh my God, that alone is a nightmare. It took me about a month to balance this. Okay, so what did we recommend? We recommended something different, right? That you have to have a cardiac echo, because the cardiac echo will give you the stability of the heart, whether you can beat it or not. So, and so about 50 to 70% have hypertension. And if your echo tolerates it, we actually recommend a blood pressure of 85 millimeters of mercury, and should be at least 65 as the minimum. And the reason for that is the amyloid study and many laboratory studies, mine including, that when you get to about 80 degrees, especially when the autoregulation starts recovering, then you have a better outcome. So the trial was negative because there was really nothing there. It's not even reaching the brain. Okay. So again, going back to all of this, there's no such thing as a one-size-fits-all, right? And us as neurologists, I think we need to be motivated to find a way to have something at the bedside. I don't know what it is. Is it TCDs? Is it EEG? I don't care. It is some kind of brain imaging. Something probably that you guys will develop. I'm already old. I probably have a good 10, 15, or maybe Laura will not say that yet because she's a little bit more senior than me, but we're still fighting, right? But anyways, so we need to move the system, right? And I know Caleb is younger. He was my Were you a fellow or resident when I was a resident? Anyway, so let's talk a little bit about neuroprognostication, and I'll be very fast here because we have 5 minutes left. So for all of you, this is what you're familiar with. So this is the AAN Ilkovadix guideline, right? So you see this, you probably have this little card in your pocket. When you have this is what you have, and your false positive is this. The only problem, what's the only problem with this? What's the main problem with this? None of these patients have therapeutic hypothermia, 0, right? So if you have a patient with therapeutic hypothermia, throw this card away, okay? We're trying to change this, but they made us wait for 3 to 5 years. ILCO is mad, and I've been writing them like crazy. Anyway, so you also have to look at what does false positive mean, right? It's the error rate of that particular measure in terms of prognostication. Because the problem is we all just look at the p-value. We don't actually look at the false positive rate. If at the end of the false positive rate there's a p-value of p less than 0.05, we feel good about it. But you have to understand that if something has a false positive rate of 30%, it means that 1 out of 3 will be wrong. Is that acceptable? No. But in the AAN, it's all less than 1%, right? And here's the thing. So this is actually from the Curing Coma campaign of the Neurocritical Care Society. And I think Ariane is familiar because I think she's part of that working group. And one of the things that we found, so I was in the neuroprognostication section, is that in a lot of neurological entities, acute neurological entities, one of the biggest reasons for death is not natural, is really related to or preceded immediately before by withdrawal of life support. So when you look at it here in cardiac arrest, 90% of the deaths, right, on the 1/3 in the first 3 days are preceded by withdrawal of life support. TBI is 50 to 70%. Intracerebral hemorrhage early on, 25%. Subarachnoid hemorrhage, 43%. Acute ischemic stroke, surprisingly, can go up to 40%. Withdrawal of life support as the cause of death, right? It's good to find if really there's no hope. But the problem is we have no good tools, and all of the things that we have is just the bias of the clinician standing at the bedside. Now, having said that, so for cardiac arrest, we created a panel and looked at all of the cardiac arrest prognostication studies there. And the vast majority at this time, there was no so this was published in 1919. There was no prospective study. And the sad part is there was no blinding, which is sad, right? Because when we do when we do clinical trials, we blind them, we balance them, and we all this, right? So the top end of the clinical trial is so heavy with all sorts of adjustments and objectivity, but the tail end, when they die, there's none. You just go in there, oh, this patient looks bad, let's take away the plug, right? And they die, and we blame the drug that was there for the failure. But when you look at prognostication, at least in neurocritical care, none of them they don't even have an adequate sample size. Most of them are convenience studies, 60 to 80%, and almost all of them are not blinded, which means that up to 95% of these studies are subjected to self-fulfilling prophecies, right? Which is the worst. Like there's a new study right now on Bayesian calculus. I mean, it's beautiful. So the title is Bayesian Prediction is Improving, blah, blah. But the problem is the withdrawal of life support is 40%. So it still doesn't matter. But I have no more time. And so these are the things that you could see that, for cardiac arrest, the cause of death, they're all here. And the purple is withdrawal of life support. But as you look, many studies right now, like, for example, in places like Brazil or China, so we're seeing now that the deaths are actually less as you keep, and there are still survivors. 7, 10 days, 12 days in this group, right? Up to 13 days. There's still about 10% that have meaningful outcome. And then you have Jan Klassen's thing about covert consciousness that we really don't know unless we do EEG. Okay, so ongoing research. So this is just 2-minute run. So IceCap. Okay, let's talk a little bit about IceCap here. So this is the study where NIH funded, NANDS and NHBI combined forces. So our study is, can longer durations of hypothermia improve patient outcomes, right? And so these are the centers. If you look at it, there's about 60 sites. I don't see NYU. Maybe we should add NYU here, right? I see head nodding. So let's add NYU. And this is the trial. So this is how the Bayesian is on the first burn-in. We have 12, 24, and 48, 150 patients. If we see that there is more patients that are improving, that is where we put more bins opening. So we keep going until we get to 1,800. So it's that, and then how do we do this? So there's a component, precise Kaplan-R1, that we do very early EEG and very early MRI, because we're able to see which patients, based on this cluster from Pittsburgh, actually respond to treatment. So this is not a prognostication study, but rather identifying which patients respond. And I see Laura standing, and it's already 9 o'clock, and that is my email, and thank you so much. Email me, and I really hope NYU becomes a center.